Welcome to the Objective Recovery podcast, where we talk about addiction and recovery very open-mindedly. Today's guest is Dr. Arun Gupta, who is an addiction specialist physician. He also does a lot of advocacy for improving the recognition and treatment of opioid use disorder, and this is what we will talk about today. Arun also published a passionate and solutions-focused book called The Preventable Epidemic that is linked in the description, and I highly recommend reading it. Dr. Arun Gupta, I'm so glad that we can discuss this important topic today. Why and how did you become an addiction specialist?
Well, nothing specific happened. Most doctors work in the office, in the hospital, and the nursing homes. In addition to doing that for 30 years, I was also involved in several other things in my career. I was a deputy medical examiner where I would investigate the cause of death in accidental deaths for 8 years. I was a jail physician part-time for 12 years. And I also worked in the emergency room for nearly a decade on a part-time basis. So I had a kind of global overview of human suffering in different locations, which most physicians are not fortunate to do that. In the year 2006, I was relieved of the jail duties and I had given up the other responsibilities. So that's some time. But what was happening is from mid-80s, way before the OxyContin story came up, I was working in downtown Detroit, and I was a medical director of a unit that treated people with substance abuse disorder for medical issues. We had no treatment for addiction, but when they had open wounds, endocarditis, those kind of things, we took care of them from a medical standpoint. So I have seen that from a very earlier stage before 1995. And then I started seeing young people were getting addicted and dying from it. And I wanted to learn how and why this is happening. I became a member of American Society of Addiction Medicine. I didn't have any addiction issues. All my kids are doctors, so there's no family issues about addiction or people dying from this situation in our family. I've been very fortunate, and this is my way of giving back. I also felt as a human being, as a physician, our job is to save people from dying and prevent them from complications. So for me to see that 300 plus people are dying every day and we do not want to do anything about it is not acceptable. So I'm trying to provide advocacy at a national level so that we have better ways of taking care of these patients. Patients have better access to us, and the physicians are not intimidated by the regulations and the insurance companies trying to help these difficult patients.
Thank you for this choice, because I work with many doctors and most of them actually just avoid this specialty, and even dealing with it, including some of the doctors that treated me as not even for addiction. They don't even want to listen to it very much. So it was a very brave choice, I would say, that early on from your side. So tell us a bit about your practice. What do you do? Do you treat every kind of substance use issue, or do you focus?
Yeah, so I've been a primary care physician for almost 40 years. In 2006, I started learning addiction medicine after I became a member of American Society of Addiction Medicine. I'm very fortunate for the knowledge they instilled in me and the subsequent education that I got, and most of that was by myself. And yes, my main practice for addiction is opioid use disorder, but people come to me for alcohol and other issues. There is not very good treatment for cocaine or marijuana type things, and smoking medications are not as effective either. So yes, but I deal with most all conditions, yes.
There are some statistics showing that there has been a small decline in the rate of opioid-related deaths in the last, I think, 2 years. Do you see this in your practice? I guess maybe not deaths, but do you think this is reflected in addiction itself, or is just the death due to the availability of treatments like naloxone and so on?
So I am a national speaker and I have national data. During COVID, the death rates went up 30 to 40% from 80, 90,000 to 114,000. The federal government has stated that there's a slight decrease in the overdose deaths in 2024. The final number is not out. It is primarily from two reasons. It's not because I or doctors like me are treating more patients with in MAT with Suboxone or Buprenorphine. It is because we are using a lot of Narcan, so we're preventing overdose deaths to some degree, even though they may be repeat offenders. And secondly, we have increased awareness about the fentanyl, and so maybe less people are trying to use it. So the access to care has not improved, but the awareness is increasing. So that may be a contributing factor for a slight dip, which may be 5 to 10% as compared to the 30-40% raise in the last 3-4 years.
So in your practice with your patients, do you see that the way they see their condition is it's more efficient for them now to get better than, let's say, like 5-10 years ago?
So my patients are doing very well, 85% success rate. They don't go through withdrawal, they don't go through overdose, they stay in remission, and they do very well. So my patients don't die. It's the people who are not in treatment. 49 million people are at risk of substance use disorder from multiple substances. 0.4 million people are in treatment. Rest 47 million have no access to care. These are the people who are dying. And unfortunately, less than 7,000 providers like me in this country out of 1.8 million doctors, nurses, and NPs provide care to these patients. And virtually now, the street drugs are responsible for 100% of the death. So it's not doctors, it's not prescription medication. And all the regulations that are put in place in the last 15, 20 years are still in place. So and we have not created new regulations how to control the fentanyl issue, which is responsible for 100% of the deaths.
Can you speak a bit about? I remember in your book that you write there also about the regulations that control and basically limit the care that physicians can provide. Can you give us a bit of updates? What's the state of that today?
Yeah. So the first thing that you want to know is in 1999, the CDC had reported that 19,000 people had died of poisoning, of which about 4,000 were from the opioids and the rest were from alcohol and other things. And so the 106th Congress passed a law called Data 2000, which allowed doctors like me take a limited course, pass an exam, apply for an X waiver, and then become addiction providers. And that's how I started learning addiction medicine. But that law had restrictions because it said you can only treat 30 patients per month for the first month, and then you could go to 100 patients, but you have to reapply it. And that would create a problem for the patients because there are audits with DEA, there are audits from SAMHSA, audits from insurance companies. So the physicians were intimidated. I had a lot of audits myself, and it made life very, very difficult. But that law said no other medications have such restrictions, including the prescription drugs that people get addicted and die from. Like many well-intended laws, the unintended consequences of passing this law is very significant. So when a law is passed, there's pros and cons. Some people want this thing, some people want that thing. So everything is put in there. And I think that led to the criminalization of the treatment arm. The second problem that occurred in 2005, the federal government reviewed the Data 2000 and said there is a little bit of diversion of Suboxone, buprenorphine on the street. Means people were like they were trading OxyContin and other pain pills, Vicodins and Norcos. They were trading Suboxone. So think of this, from 1995, OxyContin abuse and overdose deaths is going up. We have a treatment arm in 2000, and then they put a dagger in it saying we're going to monitor the diversion of Suboxone as it impacts the communities. So the treatment arm didn't go up. If that would have gone up without restrictions, we would have had less number of deaths. But they slowed down the treatment arm like this, and that created this problem, which I call criminalization of the treatment arm. The third problem that occurred is the federal government sued the company that makes Suboxone. It was 𝗔𝗺cie in the big name, 𝗔𝗺cie, and then it renamed Endeavor for $2 billion. Okay, so Purdue Pharmaceutical got off the hook. That created the problem with $4 billion, while Purdue Pharmaceutical got off the hook, is on the hook still for $2 billion. So these are the kind of regulations that has created a problem. Now, to answer your question, what I wrote in the book is called Barriers in Treatment. The first barrier is called Harrison Narcotic Tax Act of 1914. It was passed by the American federal government to control the trade of illegal drugs around the world, and obviously the money. It said a lot of things, and I had a couple things to point out. One, it said addiction is a moral failing and is not treatable. A physician cannot write another addictive medication for addictive condition. So methadone got approved about 60 years ago, and the physicians were forbidden to write it. It could only be dispensed through the federal OTPs. And then Suboxone got approved about 25 years ago, and it got very, very restricted and limited and overly regulated. So the access to care didn't improve. Had they made Suboxone a commodity drug like for diabetes, hypertension, and provided physicians with the education, the treatment arm would have done much better, and we would have saved so many lives. So that was the first problem that I found was an issue. The second barrier I found is, even as of today, uniformly, majority of the medical schools in America or around the world do not teach addiction medicine. Yeah. And so the doctors lack training. If doctors are not trained in addiction, they are less likely to deal with those patients. These patients, when they're unstable, they're very difficult, complicated, and have a lethal condition. So if we are not trained to take on these patients, these people are going to die. Now, my impression was that the psychiatrists deal with these mental issues and they should be trained in addiction medicine. So when I was researching for my book, I looked at what things the psychiatrists are trained. They train in anxiety disorder, eating disorder, mood disorder, personality disorder, psychotic disorder, and specific eating disorders. So they're not taught addiction medicine. And I said, this is not possible. So I called some of my academic friends at Harvard and Yale who were in psychiatry, and they said, that is true. So even that arm did not work. The third problem I find is there's a lot of stigma in addiction. And even though the Supreme Court ruled in 1962, addiction is not a moral failing, it's a treatable chronic condition, the mindset in the insurance companies and the policymakers has not changed, and the bureaucrats. Unfortunately, the stigma towards the disease, the stigma towards the treatment, and the stigma towards the success of the treatment. So stigma towards the disease, as it said in the Harrison Narcotic Tax Act, then the stigma towards the treatment is a lot of these groups like A's and NA's feel that patient is on one medication versus the other, so it is substituting one addiction for the other. Buprenorphine or Suboxone, I could guarantee you, scientific literature, it is not addictive. We had a doctor in our town who got apprehended about a decade ago, and I got scared. I was successfully able to talk to the patients and reduce their buprenorphine by 30%, and they all did very well. And in the next couple of years, I cut down more than the 10, 15%. Now, unfortunately, what happened is during COVID, people got scared. People had no social life. People felt they could relapse. So I had to give some 10, 15% back buprenorphine, but they're still below the pre-COVID level. So buprenorphine is not an addictive drug. Yes, occasionally people can abuse it. There's also success towards the treatment. So I have hundreds of patients, and they are not willing to come forward because their work may not know what they were doing. Their extended family may not know, kids may not know. So they can't come and tell, hey, how bad we were and how well we are doing now. So unless the media can showcase these people, we've not been able to fix the stigma. Now, I have attended a lot of conferences at a national level about stigma, and everybody says, let's reduce stigma. I said, it's not that simple. It's not like I'm going to step out of the house and it is going to rain, and I'm going to pull my umbrella and I'm going to be dry. We need to put in efforts for everybody to have mandatory education on several topics on vocabulary, empathy, humanity type of things, or we're not going to fix this problem. And those have to be, educational material has to be generated by some academics. The fourth problem I find is that the buprenorphine, the treatment medication, got criminalized. And so we need to decriminalize that and so that doctors can write buprenorphine. The fifth barrier I find is what we call the regulations that have been created to control the pills and the pill mills, doctors and the pharmacies that were dispensing too much of Suboxone. We have come up with nearly 500 regulations in the last 15 years. And there was a town hall meeting between University of Michigan and Harvard that happened in Michigan 6 years ago. And Dr. 𝗂𝗺𝗱, one of the speakers, said, these regulations have been controversial or blunt instruments. In simple language, she said that they either did not help or may have made things worse. So that became another barrier. The next barrier I find is street fentanyl. Now, mind you, the prescription fentanyl that I use or doctors use an outpatient as a patch for 7-2 pain control is a different medication, and also the surgeons that use fentanyl for pain control during surgery. That is very useful product. We started seeing fentanyl in a drug test in these addicted patients in 2014. It took federal government 3-4 years to figure out where is it coming from. It was coming from China directly to the American labs. And now in the last 5-6 years, it's coming directly through the open borders, and the death rates have escalated 30 to 40% because of the easily accessibility and fentanyl being very lethal. So I have been proposing for the last 5 years, let's differentiate between the prescription fentanyl to the street fentanyl like we have for amphetamine versus methamphetamine. One is an L isomer, one is a D isomer. I'm sure the street fentanyl could be separated from the prescription fentanyl. And the federal government could use one of the following wordings. It could be considered as a poisoning, a federal crime, a public health crisis, war against America, a weapon of mass destruction, and then we can reschedule the street fentanyl only to class 1 drug. Now, if you go back to look at the class 1 drugs, like even THC marijuana is a class 1 drug federally, but legal and decriminalized in 34 states. So the laws against class 1 drugs are also very soft. We need to strengthen those laws to be more effective. The next problem I find is the doctors have been criminalized. Now think of this, that the very doctors who could take care of these very sick patients, 1,000 of them have been apprehended by the federal government or the state government, and now the others are scared. In any other profession, whether it's a dentist, a lawyer, a teacher, a pilot, a politician, they can have addiction diagnosis and continue to work. But the doctors cannot. They have to go through HP programs, and it's a long, lengthy process. But so the doctors have been criminalized. Now, the other reason doctors hesitate to do it is the bigger institutions are not supporting this process of treating addiction. Nor are they funding, nor are they providing us education. There's lack of knowledge, lack of skills. In fact, last year, one of the JAMA's magazine called Medscape had an article that says all those things. And I think we need to pay attention and hold bigger institutions responsible for right funding and providing knowledge and support the medication-assisted treatment. And like I said, the treatment arm has been criminalized right from the beginning with the Data 2000, with the X waiver, and then they put a diversion control plan. There was never a diversion control plan on the OxyContin and Norcos or any of those prescription medications. In those 25 years, they had been approving stronger and stronger pain medications, and nobody wanted to stop, rethink about it.
Yeah, thank you for this excellent, very deep and rich overview. So just a few reflections on this. First of all, the stigma issue that you mentioned, that addiction as a disease, the disease concept, many people still don't like it. Actually, what I see in my own practices, which is not a medical practice, is people even including people who have been trained in psychology and have been some of them have been treated for they come from a personal experience background. Many people are psychologists very against the disease idea, and I see. So I just spoke with I just did a podcast yesterday with a group, and they were asking me questions about this, even trying to push me to almost to change my mind that addiction should not be viewed as a disease. And I think one thing that people misunderstand about this is that when we speak about disease, people equate that with something, a terminal disease that cannot be cured, right? So that's how they see a disease. They don't realize that actually most of the diseases can be treated and cured, and addiction can be one of those.
Personal biases, lack of education, lack of open mind, and in some ways it may help them with their own subconscious thinking and thought process and lack of knowledge and justifying. So I had a situation 4 or 5 years ago, and I did a presentation, and the jail administrator was in the audience, and he said, "Oh, you didn't talk about counseling." I said, "Counseling is available everywhere. That's not what I'm here to educate the public. I'm here to tell what is missing, what needs to be added to it." And he still holds a grudge against me for that thing. And so same thing is just like, nobody sends me patients. Patients come to me by their word of mouth, the hospital, the local doctors, the counseling services. I'm not even on their list of providers where they can go get help. But I have their names on my list of providers where they can go get help. And so like we had funding in our town, small town, for opioid crisis. 24 people applied, including I have a 501c3 for doing this work. And guess what? 23 people out, 24 got money. I got 0. And the word is, oh, he's a doctor, he doesn't need it. But they don't see my other side of the work that needs support. And so it is very difficult. When my patients go to an emergency room, or even they go to the pharmacy to get the prescription filled, or they have to see a specialist or go through surgery, they are, or somebody's pregnant, they have to go through delivery, they are treated like they repent going there. And they said, "Doc, if you can take care of everything, we do not want to see another doctor, another pharmacist, and whatever." That's what I'm saying. We need to create education for everyone.
You mentioned that in medical school, basic medical, I know I'm very familiar with that because actually I do consulting, and sometimes I have done, I don't know, many times, even went to conferences and gave neuroscience lectures to groups of physicians who even, usually it's a mix of psychiatrists and addiction specialists and other specialties. And so why is it that it's kind of avoided in basic ed?
So the agency that controls the education is called ACGME, Graduate Medical Education Council of. So they have tried to indirectly approach them 6-7 years ago, and they have not changed the medical school curriculum. The answer I get is this is a very complex situation. It takes a lot of resources and funding, and they do not have that. I don't think that's a good enough answer. Even if you educate 1 week of addiction medicine in medical school, the physicians will have some training and they may not practice. So had they done it in the year 2000 and 20,000 physicians are being produced every year, in 25 years, we would have 500,000 physicians who had some knowledge versus no knowledge. Okay. Now they're saying that you have to do 8 hours of course to get your license renewed for XDEA or state license or similar licenses. There is no controlled education of what they're doing the 8-hour CME on. So yes, people will click onto some computer program and get a CME certificate, but they're not going to be trained enough to do that. So that MATE Act, Medication Assisted Treatment Expansion Act, was passed in December of 2022, went into effect June of 2023, and they were hoping a lot of doctors will get into the program. The problem is all the state and federal regulations that have been put in place in the last 20 years are still in place. So until as those regulations are reversed and expunged, more doctors are not going to risk their license and go to jail and become homeless taking care of this difficult situation. So the government has to be mindful that doctors should be allowed to treat patients without the intimidation, and there has to be some education and incentives to do that.
I actually experienced a form of this, not with opioid, but when I had my alcohol problem, I went to my primary care physician and asked for, because I was knowledgeable about available medications for that. So I asked for him for naltrexone, and he did not know. He told me straight that I would have to refer you to a specialist. And so I asked him, "Are you sure?" And then he checked online and then said that, oh, it seems like I can actually prescribe the
Yeah.
So I got it through him. But and now, I still see him every year for my medical needs. And so now he uses that medication with other patients as well. So he was very open-minded to it. But it was so interesting because he was not a young, beginning of their career, a doctor. He was like mid-career, and so never used this medication. So I have also a question about the regulations. So you mentioned that you have this idea that street fentanyl should be regulated separately from the medical fentanyl.
Yeah.
Yeah, so that's actually a very important point because there has been a lot of discussion. So I'm sure you are aware of that act. If fentanyl should be treated as Schedule 1, and then many people are against that. So you propose that they can be discriminated, the street drug.
Chemically, yes.
Do you think that can actually be done in practice? Can you just say a bit more about how that can be done in practice, in everyday practice?
Yeah. It's not for you and me. It's for these scientists sitting in the labs, chemistry scientists. So I gave an example of the amphetamine. Amphetamine molecule, L-isomer, is legal. That's how I remember it. L for legal, D for drug. So L-isomer is amphetamine, and the D-isomer is methamphetamine.
Yeah.
Okay. Similarly, the scientists and researchers should be able to separate the prescription fentanyl that we have Schedule 2 versus the street fentanyl that I'm saying should be Schedule 1, chemically and structurally differentiate in the lab, and then label that as Schedule 1 drug. Unfortunately, there's a bill in the Washington on the floor right now to make the entire fentanyl class as a Schedule 1 drug.
Yeah.
So that is a problem because the researchers and scientists and the doctors who need to use it will make it more difficult.
Yeah, more difficult.
So they need to understand what I'm saying. The street fentanyl could be labeled as poisoning, federal crime, public health crisis, war against America, weapon of mass destruction. The federal government could use these adjectives to reschedule the street fentanyl to a class 1 drug, but leave the prescription fentanyl as class 2.
Okay, thank you. I was actually confused about this myself, so I kind of supported the recent act that you mentioned, and now I think I will think differently because definitely I think it can be a bit difficult in everyday practice to always test, or during the arrest, but that's a different discussion. And let's speak a bit about the opioid use disorder itself. So what do you see as the causes of opioid use disorder?
There's a very high correlation between mental illness and addiction,
Yeah.
about 2/3 of the times. But before that starts, there is a thing occasionally taught in the academic setting called adverse childhood experiences.
Yeah.
And we definitely do not talk in the clinical sense. So, what is happening to the child in the first 5 years of their life is going to determine what kind of personality this person is going to have. And if the first 5 years have been traumatic and bad, whether it's emotional, lack of love, abuse, neglect, mental abuse, physical abuse, sexual abuse, you know, no food, people are using bad languages. So that exposure is very crucial how the person is going to behave. And we do not have the resources to go to that level to fix the problems moving forward. So the kid can't complain. The parents may not be in the right state of mind or the broken family. So all we deal with is an adult who is kind of messed up and then they have a little bit of smoking or marijuana, alcohol, and then they blow up. And so those are the main causes. We tend to say genetic, yes, that plays a role, but environment plays a bigger role also.
This was also one of my main research interests for many years. I actually studied the neurobiological mechanisms of the early life trauma and, how that is maintained and why it's so persistent, epigenetic mechanisms and others that maintain that. And so just trying to develop approaches to target those, but it's far from being ready to be used as treatments. So what do you use as treatments in your practice for opioid use?
So FDA approved buprenorphine, but by itself, it could be injected and abused. So the research showed if you put a small amount of naltrexone into it, an 8 milligram versus 2 milligrams of naltrexone, then if they crush it and try to inject it, they're going to have side effects. So it's to deter people from abusing it. Doesn't prevent 100% of the people. Some people may still be able to do it or uh, kind of override the side effects. That is the main form of treatment. It has been available originally by as Suboxone. Then another company came up with Subzol, and the third company was Buprenorphine. Buprenorphine folded because there was not enough market, and they could not show the purity. Since then, it has been available as an injectable form also that you get once a month, but it's very expensive, but $1,800 a month, the cost of the medication. We can also use Vivitrol injection, which is again same thing as the naltrexone and the Revia pill. It blocks both the opioid receptors and it also blocks the alcohol receptors. But the efficacy is kind of low in general population with these medications. But if you have a professional person like a doctor or a lawyer or a pilot and their license is on the line, the efficacy does improve with appropriate counseling and guidance.
So the main treatment is Suboxone. Then,
Yeah.
is there any is there any kind of individual variation in terms of who is a good candidate for it? Who is it more effective for? Can you judge that in your patients?
Well, so most people who abuse narcotics are eventually going to die sooner than later from overdose, or they will have miserable life going through withdrawals. And that's why they keep on providing clean needles and clean heroin. And in Canada, they even providing clean fentanyl now in Vancouver. And the American people are demanding that for the last couple of years. So anybody who's abusing and is at risk of dying and overdose should be in treatment. Now we're doing a lot of Narcans. I have a Narcan dispenser in my office. I've dispensed more than 500 Narcans free. I'm saying if we put buprenorphine next to that Narcan, or we have a mechanism that we can go and give Suboxone because the regulations of putting that in a free bin, then these people don't have to look for the next fix.
Yeah.
You give them a $5 sandwich and a free buprenorphine will save a lot more money. I'm even saying when an ambulance or EMT goes to revive a person with for overdose and they give them Narcan, whatever, oxygen and stuff, they should, after the people wake up, they should give them Suboxone and 3 days of Suboxone and say, hey, go see this doctor in the next 3 days. You know, we have to get more progressive in trying to save these people. Giving Narcan is only preventing overdose deaths. It's not putting them in remission. It's not putting them in treatment. And if they're not provided the tools how to get help, they will never get help.
What can help patients comply with this? Because medications, many people, in my experience with others, even with this, is that people start using it and then they change their mind, they relapse, and they just never continue treatment. So so you say that your practice tends to be very successful. So what do you do? What can be done to make it more?
Patients come to me by the word of mouth. So these people have hit rock bottom and they've heard Dr. Gupta can help with, I'm the only physician in town in a small rural community, been doing it for 18 years. And they say, oh, I want to live, I don't want to die. And, or I have a family, or I want to enjoy life. And so I've been doing it for 18 years and I have very high success rate. And I see 15, 20 patients a day and they all want to get help. I have 15% non-compliance or people who are not fully motivated. They want to play games, they want to go sell Suboxone, or they're still not sure they want to be in treatment. I cannot do anything with them alone myself. I send them for counseling, IOPs, inpatient rehabs if necessary. But if 85% of the patients can be tackled at home, and we have 1 million inpatient beds in this country, we should have this problem in crisis. So even the inpatient rehabs, patients there need to have outpatient follow-up. When people are discharged from the jail, hospital, and the nursing homes, they need to have an outpatient follow-up, like for diabetes and hypertension. We don't have enough providers in this country. Like I said, we need 200,000 providers actively participating geographically in a uniform fashion to contain this crisis. We have less than 7,000. So we are way far behind how we can tackle and contain this problem.
Do you, in your practice, do patients usually stay on the Suboxone long term, or is the idea to treat them for life with it, or do also some of them eventually get off?
It's a very lethal chronic condition, just like diabetes. Let's give an example. A new patient comes to the hospital, has a 600 sugar, normal is below 100. We hang IV fluids, we hang IV insulin, we bring the sugar down. We don't tell the patient you don't need medicine. We write oral prescriptions or insulin, whatever is necessary in the condition. And they need to take that for the rest of their life. Diabetes is not that lethal condition as addiction is. Yes, it's a chronic relapsing lethal condition. People are going to need medication for the rest of their life. And that's a mindset people have to change, both by the insurance companies, policymakers, and the patient and the families. I could tell you in 18 years, I probably have 4 or 5 patients who successfully weaned down and got off Suboxone.
Yeah.
But still come and say, Doc, I'm alive, I'm doing well, but I don't need it anymore. But majority of 99% of the patients are going to need the medication.
Okay.
90% of the patients with addiction will require medication-assisted treatment. It's the people who are just doing occasional stuff, may not need it, or not having higher dosages of abusive drugs may need treatment. But 9 out of 10 patients would need medication-assisted treatment help.
Are there side effects that make people hesitant to stay on it for a long time?
No, it doesn't affect the brain, the heart, liver, the kidneys. sublingual absorption, and it doesn't affect the blood pressure, your blood counts, your sugars, cholesterol, nothing. It has no effect.
Okay, and mental side effects?
In fact, mentally, they feel a little better than most other people who are not in treatment. It may have a mild euphoric effect from the being an opioid agonist.
Yeah. Hopefully, some people, it will help some people, because I find myself that one of the main reasons that repulses many people from seeking medical help, because they have this the idea that they don't want even to start medication that they will have to be on for life. So, but it's very interesting. It just says about the addictive mindset, how that works, because the prospect of dying from addiction, or just destroying their life, that's not as repulsive. So I think that's the kind of balance that people need to weigh.
I had a lady today. She's in mid-30s. Her mother was addicted. She died a few years ago from lung cancer. Her husband, a would-be now ex, has addiction and is in jail. The 18-year-old daughter died of cardiomyopathy, God knows for what reason, last year. And she was just crying. And I had a new nurse practitioner student in the office, and she was telling a story. And so this is a very disturbing condition that ruins the families. And we need to save the families from destruction.
I had this question for myself, again, for my own treatment for alcohol use. And so I just discussed it with one of my guests about that topic a few weeks ago, that so the use of naltrexone for alcohol use disorder. And so that's the way we use it. It's just we use the medication only when they drink. And that's also the same. So I had to accept, I actually had to deal with this dilemma within myself, that I don't need to take the medication for the rest of my life every day, but I will need to take it every time if I choose to drink in the future. And I accepted that that should be the case. And I just chose eventually that I'm not going to drink, because it was just an easier choice. But it's still, it's just the perspective of, just really looking at it. And I think it really helps in the beginning, when someone is already in treatment, they feel a bit better to that their perspective becomes clearer in terms of long term and so on.
Did you feel any side effects from taking Rivia?
So yes, so that's why I like to ask this question, because so that was so my treatment was naltrexone alone, and definitely yes, and that was actually for me. I used it in different ways. So in the beginning, I took it every day, and so definitely I had like nausea and other like mental side effects, because that the medication is more like it's not euphoric, it's the opposite. So I had a bit of like a low mood and other similar low.
People feel depressed.
Yeah, and so, but it
Euphoria from the alcohol is gone, and then you can't drink alcohol, or you're not drinking alcohol. So yes, people.
Yeah, and so I definitely felt it, and so my treatment eventually became that I used I use it together with alcohol, and this extinction type treatment. So that worked very well for me. But as that progressed, I had more and more days when I took the medication I did not drink, and then I felt the side effects more acutely, because there was no alcohol to kind of counteract that. And that was, for me, it was an incentive to actually not drink again, because then I don't want to take even the medication anymore. But I definitely still have the view that I will definitely, if I ever, it's not a question for me. That side effect was super mild. People can, that mental side effect, I learned to deal with it, for example, to engage in some physical activity, and, it's just to basically distract myself, because the side effects were only acute, for lasting only for an hour or two after taking the pill, and then it went away for the rest of the day. And so I could basically structure my life around that, and definitely I was very motivated. If someone is less motivated, then of course they use anything, any excuse, or any discomfort to stop the treatment.
I still offer antabuse, naltrexone, both oral and injectable for those conditions, and I probably have like 20, 30 patients who would take those kind of medications for alcohol use disorder.
For alcohol use, just curious, do you prescribe it as a daily treatment with abstinence, or do you use this so-called Sinclair method when they
So,
drink on it?
so when they take antabuse, they can get sick, violently sick, because it reacts in the liver. And so these people have to be motivated not to drink. When they have naltrexone, it reduces the quantity and frequency of patients' ability to drink by 80%.
Yeah.
So instead of drinking 2 bottles of wine, they're going to have a glass and a half, and then they're going to
Exactly.
drink. Same thing with the injection Vivitrol, but the legal system likes the injection Vivitrol.
Yeah.
So that peace of mind, hey, okay, this situation is contained.
I just spoke with someone who lives in Australia and is also in the addiction treatment industry. And so he was telling me about the naltrexone pumps that they use there. So it's different from the injection. It can be, the dosing can be more like, it can be dosed better. So it's much more supported there. I think here in the US, we don't use that treatment very much.
So what I do with alcohol use disorder is I see a lot of these people in the later stages have trouble sleeping. So, and that is part of the reason they may be starting to drink more. So what I do it is I try to write either a tricyclic antidepressant, SSRI, in some cases mood stabilizers, even antipsychotic medications, so that they can sleep. And then I titrate them myself so that if we don't control their sleep and their emotional issues, they're not going to quit drinking.
Yeah, yeah. It's actually very, very important, the sleep. That's actually how I started, how my problem started. I was not very young. It was, in relation to very hectic lifestyle. And I tried to very, just not really sleeping normal schedule, like, just work night shifts and things like that. So I had this brilliant idea that I would use alcohol to regulate my lifestyle. Of course, already where it led to. So for that, the naltrexone treatment was excellent for me. After everything else, I tried so many other things. Everything failed. That worked. That eventually, and I'm no longer drinking. I don't drink at all. So
Well, proud of your achievement, personal achievement.
thank you.
Congratulations. Yeah.
Thank you very much. So let's speak a bit about the alternative treatments. I'm sure you are aware of, innovative newer treatments. I'm interested both because, as you know, many people opioid use disorder starts as grows out of their pain medication treatment, and so I'm interested in your opinion on newer, non-addictive, non-opioid medicines, and also any, for opioid use disorder, someone already has alternatives like medical devices and other.
Yeah. So some of these things are not available clinically.
Yeah.
Think of this: if we have 49 million people documented to be either addictive to stuff, or maybe 100 million people that have chronic pain. So the companies have to put a lot more efforts to promote these products or drugs than what Purdue and the other companies did in the last 2 decades to make a big difference. The cost, the availability, the prescription. So it's a big work, and I do not think it's going to be as good or as effective as OxyContin was in containing the issue. So a lot of it also depends on public acceptability. So if you have free Narcan, which costs $50, and you can come up with these devices or the new medications which work on the chloride ion channels in the brain and not directly affecting the pain receptors. So these products have to be more widely, easily available and be cost effective. The copays and deductibles are huge, and the benefit and long-term benefits have not been studied beyond a few weeks. Then it's not going to be easy for people to start taking those medications.
Actually, I just started working with researchers who plan to do a longer term study on the suzetrigine, the name of that medication that you
Yeah.
mentioned, the sodium channel
Direction.
blocker, and that's exactly some of the questions that we want to explore the long term effects and how to deal with it. So your view is you are not very optimistic that they can replace opioid medications in the long run?
You need a much larger workforce.
Okay.
So, and it depends on the company's R&D and the budget and public's acceptance. Once you are on opioids, you first have to get them off the opioids by something like buprenorphine.
Yeah.
You cannot just transition them from, these people are not visible most of the places. They're hiding in the basements. How are you going to reach them?
So that will be challenging. That's my view as well. And it's again the question is also that even if it's available, will providers, doctors trust it, or will they adopt and integrate to that practice?
Most of my physician friends have not heard of these products.
They have not? Okay.
No.
So that's again, it needs to be part of the education, continuing education, to hear about all these treatments. What's your opinion about something like psychedelics? There is so much
So
research on that now.
psychedelics is a problem because they dissociate the frontal common sense, fright and fear with the thalamus, which is the common sense. So they create a schizophrenic effect. Like I was asked to write an article on the ketamine, and that's how it works. Ketamine has been approved for anesthesia, in higher dosages, and beyond the anesthetic dose, it is lethal. So what ketamine people are using and abusing is at the lower levels, which are, say, 2 milligram per kilogram for depression and in addition to pain medications for pain control. But if your level goes between the 2 milligram to, say, 10 milligram, it has a reverse effect on the glutamate in the brain. And so then they start feeling the schizophrenic effect. So for pleasure abuse sake, I want to have a high, I want to have a drink marijuana, you want to take these psychedelic medications, but long-term problems is going to be much worse.
I mean, there are now other like psilocybin, LSD, and all these others the idea is that to basically use it just as to initiate more like a deeper investigation of those traumas and the root causes that we spoke about. So it's kind of a different, but definitely some people respond. Not everyone tolerates it, and not everyone. Some people even for example, I'm a good example for it as well because I kind of support for psychedelics for certain, cases, and I use them myself when I was young. But I know about myself, as we discussed, that I have addictive tendencies, and I believe a predisposition. And when I experimented with psychedelics in my youth, before all these, before I became a neuroscientist and all this, what we know about it now, I started using it in not a healthy way. And so that can also become problematic and combining it with different drugs. So it's definitely not ideal always for someone who has, addictive predispositions and tendencies. Okay, so the last topic I would like to touch upon is that you wrote the book Preventable Epidemic. So do you view prevention? How do you think opioid use disorder at least can be prevented other than what you have already discussed?
Well, the reason I picked that title from a book is CDC had said long time ago, 20, 30 years ago, addiction is a preventable disease. People waitlisted for treatment have very high mortality. So that's how I picked up the title is it's a preventable disease. Even I'm going to be speaking in Calgary, Canada next month at a Rotary International meeting. And the other physician is going to speak about addiction is not about alcohol and drugs. I'm going to speak about the treatment and so we're going to have an interesting discussion. Yes. Preventable, it's going to take a long time to start educating our children from age 4 or 5 onwards about these addiction issues, and we don't have resources to do that.
There are some. I also was involved in a project recently that people are developing basically predictive tools. So one of those came out in Nature Medicine recently. That an AI tool that they use the electronic health records. So all the information there to predict who maybe who may have which patients may have a higher probability to develop problems with the opioids, and so that's they developed an algorithm, and there are many tools like this. So maybe that's also something that we can utilize in the future. It's still difficult to get people into, before they develop the program, to get them into prevent.
Yeah, even if you can figure out who is at risk, how are you going to prevent and how are you going to treat them before it gets out of hand is a problem. So just finding is not the issue, is do we have tools to fix it?
Yeah, exactly. Yeah. Okay, so thank you very much, Arun, for this very informative discussion. Last question is that how can people contact you, or is there anything else that you would like to share?
My office number is 734-241-7162. I have a website, the Preventable Epidemic book. I do have a 501c3 corporation, SOS Foundation, Serious Opioid Solutions. So yes, you can Google me, Monroe, Michigan, Dr. Arun Gupta, and so there's several ways to reach me.
Thank you very much. So we will include all these resources in the description, and so thank you again for doing this work and for
My pleasure.
today.